Bismillah ar-Rahman ar-Rahim. Today I'm going to talk about PEEP, whether extrinsic PEEP or intrinsic PEEP. When we talk about PEEP, usually we say this PEEP is positive end expiratory pressure. We set it, and we set it for three important reasons. Number one, to keep alveoli open, and usually we set it 1 to 2 centimeter water above the lower inflection point. Or sometimes we say it is 1 to 2 centimeter water above the superimposed weight or pressure. And the last one, we put this extrinsic PEEP about 80 to 85% of the intrinsic PEEP to keep alveoli open. So the PEEP itself, the main function of PEEP is to keep alveoli open. To keep alveoli open, this means that to let the alveoli do its function, which is ventilation, gas exchange, not to be atelectatic. At the same time, the VQ matching will be good. So this is one point. So you have to keep an eye on this beep. At the same time, take care that the beep itself has its hemodynamic impact, or it has its impact on the lung as an inflations. We're going to discuss that. So this is the problem of PEEP. Before we go to PEEP, I think it's better to say what is meant by PEEP. Normally, when you look at this, at end of expirations, when you exhale the tidal volume, look, there is no air moving in or outside. This means that there is no pressure gradient. That the alveolar pressure is the same like that of the atmospheric pressure or the mouth pressure. This means that this is the alveolar pressure, which is zero. This means that the remaining volume at the end of expiration in a normal person, in a normal lung, is the functional residual capacity. Look it by another way. At the end of expiration, the remaining volume is the functional residual capacity. This means that the elastic recoil of the lung inside, inward, equals the elastic recoil of the chest cage outside. So the chest wall itself does not move. So at end of expiration, no movement of the chest cage, and the remaining in the functional residual capacity. At end of expiration, the alveolar pressure is the same like atmospheric pressure, which is zero, where there is no gas in or out. This is the functions of the capacity we have mentioned before. This is the pressure here inside the alveoli, the same like atmospheric pressure, like the mouth pressure, like atmospheric pressures. But if the pressure in the alveoli is more than zero, this means that there is another volume, extra volume above the functional residual capacity, which led to the production of this pressure due to the elastic recoil of the lung. So this means that the remaining here, the remaining volume is more than the functional residual capacity. This more than the functional residual capacity. This volume produces 5 centimeter water above the atmospheric, and this one produced this larger volume produced 10 centimeter water above the atmospheric pressure. So this is so PEEP. It is an extra volume above the functional residual capacity, and we do not measure it at the volume, but we measure it as a pressure. So we call it positive end expiratory pressure. It's normal. The end expiratory pressure is zero. But if we leave some volume inside, in addition to the functions of the capacity, this will produce what we call positive end expiratory pressure, because it is above zero. Another important point. Normally, the normal lung of the when you look at this is another important point should be considered. When you look, this is the lung of adult. When you look at the distance from when in the supine position, this is the distance here is about 30 centimeter water, and the density of lung is 1/4 of water. So it means that the weight of the lung of this limb over this dependent part is about 7.5 centimeter water. This means that This alveoli in the dependent part is under pressure or are under pressure of 7.5 centimeter water. And this alveoli, in order to be kept open, their volume, the volume inside it, should produce a pressure more than 7.5 centimeter water in order to be kept open. That's why when we say that we put a PEEP 1 to 2 centimeter water more than the superimposed weight in order to keep these dependent alveoli open. This is another issue, and this will help us to understand what will happen in patients if they are this, in which the lung, all of it is full of fluids, so the weight will be larger, so we need a larger PEEP in order to keep these alveoli open. Another important point, when you look at this is the respiratory bronchioles, which is non-cartilaginous. And this usually supported is kept open by the volume inside it, which will produce some sort of pressure more than the superimposed weight. In addition to the connective tissue dragging it outside to keep it open, what we call radial interstitial force. If you make an exhalations of the tidal volume, no problem. But sometimes if you exhale more than the tidal volume, encroaching on the expiratory reserve volume, it means there is some sort of collapse and the radial interstitial force will decrease. This will lead to what we call atelectasis, especially in the dependent alveoli. So this will be atelectatic, and this means that this part of the alveoli and the respiratory bronchiole will not make some sort of a gas exchange, are not ventilated. So this will be non-ventilated perfused alveoli will be responsible for the shunt. When you put a PEEP, this means that you are adding some volume, which means that you are adding some sort of pressure to keep these alveoli, respiratory bronchiole, open. Here the problem, this is the function is the capacity which is formed of residual volume and expiratory reserve volume. In normal person, this is the total lung capacity is more than the airway closing capacity. This is the closing capacity, which is the closing volume, and this is the residual volume. This means that a normal person, the function residual capacity is high, is larger than the closing capacity. This means that the dependent alveoli at the end of expirations will be open with gas exchange and no shunt. So what will happen if this total lung capacity is less than the closing volume, or the closing volume is more than the total lung capacity in the supine position or in the erect positions? Look at this. This is, as I've mentioned before, this is the pressure, this is the volume inside. This is the volume inside the respiratory bronchiole responsible for keeping it open in addition to the radial interstitial force. This is a closing volume. As I've mentioned before, when you exhale more than the function, more than the tidal volume, you are encroaching on the expiratory reserve volume. The interstitial force decreases, and at the same time, the superimposed weight will to lead to the collapse of this respiratory bronchiole, and this is the closing volume. This is non-ventilated alveoli. Look at this. This is usually in the normal patient, the closing capacity before the age of 45. Closing capacity in the supine positions is less than the functional residual capacity in the supine position while you are asleep. So no problem, all the alveoli are functioning well with good gas exchange. But with age, look at this. With age, when you go more than the age of 60, this means that the function residual capacity, the closing capacity will be the same like that of the closing capacity will be the same like that of the function residual capacity in the upright position, So this means that in the upright positions, there's some sort of the dependent alveoli will be atelectatic, and accordingly or the respiratory bronchiole will be atelectatic, and the part of the lung will not be ventilated. So it will perfuse non-ventilated. This will lead to shunt. So this is a problem. Look. So this is a problem for the supine position and upright positions depending on the age. When you look at this when you are in the supine positions. This is the supine position here. This abdominal content push the diaphragm, and this leads to decrease in the functions of the capacity. The same thing, the elastic recall of the lung will not be antagonized by the outward elastic recall of the chest cage of the patient is paralyzed, and this will lead to decrease in the functions of the capacity. The same thing, the venous return will increase, and the some sort of lung congestions, and that this will lead to decrease in the functions of the capacity. So the functions of the capacity will decrease, and the decrease in this functions of the capacity for sure will be associated with increase in the closing volume, or it will be less than the closing volume. And in this case, these alveoli, especially on the dependent part, will not be ventilated but be fused, and this will be responsible for the shunt. Look at this as an ARDS. We have mentioned that the dependent alveoli, the pressure in it should be 1 to 2 centimeter water more than the superimposed weight. In the normal person, it is 7.5 centimeter water. But in this ARDS, the lung is wet, so the density is larger. So that's why we need a volume to produce a pressure than the 7.5 centimeter water. We need that's why in ARDS we need a higher volume to mm, uh, 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 to be 1 to 2 centimeter water more than the this high superimposed weight. That's why in ARDS we usually use a higher beep. This higher beep because the superimposed weight is high in this case. That's why in the normal, the lower inflection point here is about this is a beep. 1 to 2 centimeter water more than the lower inflection point. But look at the inflection point in the ARDS, it is large. So we need a higher beep in order to keep these dependent alveoli open because of the superimposed weight is larger than in the normal lung. That's why when you look at this is a lower inflection point, this is the upper inflection point, lower inflection point, this is the upper inflection point. This is a lower inflection point where there is a larger change in the pressure is associated with a smaller change in the tidal volume. That's why we usually put a volume 1 to 2 centimeter water more than this point in order to start from this point. At end of expiration, these dependent alveoli should be open, should not be closed, should not be atelectatic, should be open. If you put 1 to 2 centimeter water more than the lower inflection point, I expect that the dependent alveoli will be open at the end of expiration. So this is the part we usually use it. This is a segment where minimal change in the pressure is associated with a larger change in the minimum change in pressure is associated with larger change in the total volume. This is here. This is the area we measure the compliance of the lung. So this is a. But if you leave the patient without PEEP, this means that during inspiration he starts from atelectasis to open, and then from open to atelectasis. This is closure and opening. This is what we call lead to what we call shearing force, which might lead to diffuse alveolar damage or might lead to pneumothorax. And this is the lower inflection point I've mentioned before. This is the upper inflection point. Upper inflection point, this is the point which is close to the total lung capacity, where a larger change in the pressure is associated with minimal change in the volume. And in this case, usually this is a point which is usually equals about 30 to 35 centimeter water. That's why when we put the patient, we take care the plateau pressure should never exceed this point. Or if you exceed this point, this means that you are hyperinflating the alveoli, which might lead to rupture and pneumothorax or what called polytrauma. So this is a point for the normal lung. It produces a pressures of 30 to 35 centimeter water. This is the upper inflection point. That's why the plateau pressure should not exceed this value. Look at this. What is the optimal beep? This is a patient when you put a beep of 5 centimeter water. The peak pressure here produced was 24 centimeter water, and the compliance we measured it was 30 30 ml per centimeter water. When we increase the beep from 5 to 8, look at this. This is a big pressure decreased and the compliance increased. Well, if we increase it more from 8 to 12, the peak pressure increase and the compliance decrease. This means that this is the best beep to be applied for this patient. Another important point for this PEEP, extrinsic PEEP, is the intrinsic PEEP. This is a patient with asthma or COPD where there is some sort of bronchospasm and this is a spasm in the respiratory bronchioles. This leads to increase in the functional residual capacity, the hyperinflated lung, increase in the functional residual capacity. So this is encroachment on the total, on the functional residual capacity. I'm close to the total lung capacity. Intrinsic PEEP, this is usually it is present. The function means that the function of the capacity in asthma, bronchial, and COPD is increased due to air obstruction or dynamic hyperinflation and might be close to the total lung capacity. So the remaining part of the volume will be small for the tidal volume. And this may be due to decrease in the elastic wall of the lung due to hyperinflation, increase in the airway closure, increasing the airway resistance, decreasing the expiratory time with active expiratory muscles. Look at this. We say we put an extrinsic PEEP about 80 to 85% of the intrinsic PEEP. Look at this patient. If the patient here is on the ventilator and he's having bronchospasm and at the end of expirations, the alveolar pressure is plus 7 centimeter water and he needs to make some sort of triggering to the ventilator. The ventilator is closed, so the pressure in the ventilator is 0, and he wants to make triggering, the triggering value is -1. This patient needs, in order to make triggering for the ventilator, he has to make a negative pressure by -7 in order to be 0, 0, and after that added another -1 in order to make some sort of triggering. So the patient is going to make an effort of -8 in order to make a triggering if the intrinsic beep is 7 and the triggering pressure is 1. So it is a large effort. If we put an extrinsic beep by 5 and he's having intrinsic beep by 7, the patient, in order to make a triggering by -1, he first has to make an effort -2 to make this +5 and this +5. And if he is adding another -1, this will be transmitted. And so the total effort done by the patient is -3. So the patients with intrinsic beep and extrinsic beep, intrinsic beep 7 with extrinsic beep 5, he will do an effort of -3 to trigger by -1. So the effort is small compared to the patient without extrinsic beep added, no doubt, added extrinsic beep, he will make an effort by -8. So in another important rule for the extrinsic beep is to put it 80 to 85% of the intrinsic beep in order to decrease the work of breathing for the patient. So the patient, so this PEEP, we put it 1 to 2 centimeter water more than the lower infection point, 1 to 2 centimeter water more than the superimposed weight. We put it 85% of the entrance PEEP in order to increase functions. This is meant that this intrinsic PEEP, extrinsic PEEP is meant to increase the function residual capacity to be more than the closing volume. This extrinsic PEEP is meant to keep alveoli open and at the same time to decrease the work of breathing. How to define, is it a PEEP? How to define or to detect the intrinsic PEEP? This is usually when you look at the flow time curve. This is normal. The flow usually the expiratory flow goes to 0, but here the expiratory flow goes it will not go to 0, and this means that there is some sort of either this is a leak or to PEEP. When you look at this is the volume term curve, this is the inspiratory time, this is the inspiratory volume, this is the inspiratory tidal volume, and this is expiratory tidal volume starts from here. This is the blue one and ends to this point. This means that the expiratory tidal volume is less than the inspiratory tidal volume. This may be one of two. Either it is an auto beep or a leak. This is if it is a leak, it will be persistent. If it is an O2 beep, it will not be persistent because the tidal volume, this is part of it will be trapped, and the second part, the second tidal volume, the part less a lesser part will be trapped, and this is the crystal. All the tidal volume which is inspired will be expired after the reach of to the steady state. We reach to a steady state where the alveoli will be hyperinflated, the elastic recoil will be larger, sufficient enough to exhale the inhaled tidal volume. This is what we call steady state. So the auto beep in this case, the auto beep will not be persistent, but the leak will be persistent where the expiratory tidal volume will be less than the inspiratory. And this can be detected also here from flow time curve. This is the flow, inspiratory flow. This is the inspiratory time studied here, and this expiratory starting from here to this point, and this is this expiratory time, expiratory volume is less than inspiratory volume, and accordingly this is might be, if it is persistent it will be leak, if it is not persistent it will be some sort of auto beep. When you make some sort of exhalation of expiratory hold, this is expiratory hold, you will feel this is a pressure time curve. The pressure will increase due to the leak of air from the alveoli to be measured here. This is the total, this is intrinsic beep and extrinsic beep. The total beep will be measured by the expiratory hold. Here the same thing. Another important point, if you apply PEEP, in this case, what is the effect of PEEP on the cardiovascular system, especially the CVB? This is the delta change in CVB. This is the CVB, the delta change, the impact of this PEEP on the CVB. When you measure this is the CVB multiplied by the lung compliance over the chest compliance, but the last compliance will produce the value which should be added to the CVB. Usually here, if it is normal lung, about 1/3 of the beep will be added. If it is a bad lung, it is half of this beep will be added to the CVB. So this should be considered, and there is no need to disconnect the patient from the ventilator in order to measure the CVB. Complications of the beep, for sure, volume and the driving pressures will be decreased. The increase in the plateau pressures, the capillary pressure, this capillary squeeze, increase in the pulmonary pressures, increase in the VQ mismatching, increase the space, increase CVP, decrease venous return, and decrease cardiac output. So when you put this is a beep, should take care for the normal lung, COPD, bronchial asthma, ARDS, and pulmonary edema. You should discuss it, what is the impact on each lung, and the main function of the beep is to keep alveoli open, and this is very important. And in addition to this, it is to decrease the work of breathing during inspiration if there is intrinsic beep. So this is an important part. This is thank you very much for